Hello, and welcome to the effects of epidural stimulation on individuals with spinal cord injury or disease, a scoping review. My name is Hope Jervis Rademeyer. I'm a physical therapist and PhD candidate in rehabilitation science at the University of Toronto. And I'm also part of the Kite Institute Toronto Rehab University Health Network. I have no actual or potential conflict of interest in relation to this presentation. And today, our main learning objective is to identify how epidural stimulation can potentially affect different functional goals for individuals living with spinal cord injury or disease. Also, we'll learn the steps involved in a scoping review and reflect on future directions for epidural stimulation in individuals living with spinal cord injury. So first, I'd like to start off with a bit of a background on epidural stimulation and how it works before we get into the scoping review. So first, in 3100 BC, King Narmer Papyrus used Nile catfish as a source of electrical stimulation. And then we have documentation as early as 15 AD, just after that, of using lamprey eels as a source of electrical stimulation to treat individuals who had pain. And then moving on to the 1800s to 1900s, pictured down here, this is a picture of a commercial device that was sold to individuals around 1850. And in the insert here, it says it's used to treat nervous disorders. And then more moving on to the history of epidural stimulation. This is a picture of Dr. Norman Shaley. And basically, he had the idea to stimulate the dorsal columns to reduce pain. So he recruited Mortimer, a PhD candidate in biomedical engineering, and Professor Reswick, also an engineer, in 1967, and they developed the first epidural stimulation device pictured here. And they actually used it to successfully treat pain in a participant who had cancer. And then also Mortimer had connections with Medtronic. And so they developed the first commercial device in 1968 with Medtronic. And now this is a picture of more modern epidural stimulation devices. And the four major companies involved in the United States at this time are Medtronic, Boston Scientific, Nevro, and St. Jude's Medical. So how does, this is a picture of a modern unit taken from Harkin et al., her study from 2011, her research there. So this is a picture of a 16 electrode epidural array. And this is implanted in the spinal column here, spinal cord. And this is implanted approximately between L1 and S1 here. And then this is a picture of the stimulating electronics and battery unit also implanted. And here it is over here. And this is just a schematic of the spinal cord and spinal column. So how does epidural stimulation work? This is a diagram of how the epidural stimulation system may work physiologically using lower extremity motor output as an example. So over here, we have supraspinal input and an individual with a clinically complete spinal cord injury. Below the level of lesion, we have clinically silent translesional input. And then over here, we've applied the spinal cord stimulation or epidural stimulation. So now what's happening in this part is that basically the action potential generated does not reach threshold. So as a result, there's no motor output here. So then once we apply the spinal cord stimulation or epidural stimulation, we provide tonic excitatory input. It combines on the supraspinal translesional input from those lumbar circuits in this case. It increases that excitability state. So the system reaches threshold at this point, the action potential, and then it results in motor output in this case. So that's how it works in a person with a clinically complete spinal cord injury. In an individual with an incomplete spinal cord injury, it works the same way, but it's also able to leverage whatever supraspinal input is coming in. So now moving on to the scoping review. So this is the effects of epidural stimulation on individuals with spinal cord injury disease, a scoping review. And first, I'll give a little bit of an introduction. So the main objective of our review was to synthesize the effects of epidural stimulation on function in individuals with spinal cord injury or disease. So the 8 different functions that came out were bowel, bladder, and sexual function, which we grouped together, cardiorespiratory function, cardiometabolic function, pain, upper extremity function, lower extremity function, spasms, and spasticity. And next, we'll move on to the methods of the study. So we used a 6-step scoping review process proposed by Arksky and O'Malley in 2005 with adaptations by Levac et al. From 2010. So first, we identified the research question. So the population we used was individuals with spinal cord injury or disease. We also selected an intervention, so that was epidural stimulation. And then we determined studies, and from looking at those studies, we figured out which functions they addressed. So to identify these relevant studies, we used an information specialist who searched 7 databases, and she came out with a number of studies. From there, 2 reviewers applied the inclusion and exclusion criteria to these different studies. And then if there were any discrepancies, a 3rd reviewer broke ties. From there, we charted the data using Excel spreadsheets. Then we collated, summarized, and also reported the results. And we engaged in consultation throughout the process. So we had meetings about some studies that were discrepancies. And we also had some meetings about the inclusion, exclusion criteria and applying that. We also used the preferred reporting items for systematic reviews and meta-analysis, so the PRISMA guidelines, with the scoping review extension. And then as recommended by Dowd et al., we engaged in critical appraisal. And for that, we used the Downs and Black modified checklist. So here are inclusion criteria. So we used, again, epidural stimulation as the primary intervention. We used humans with spinal cord injury or disease. We included a pre-post measure of an orthotic and or therapeutic effect. So an orthotic effect is an immediate change in the parameter of interest with epidural stimulation at one point in time. So for example, if I'm looking at improving someone's grip strength and I turn on the epidural stimulation and it improves it immediately, that would be an example of an orthotic effect. And then for a therapeutic effect, this would be a change in the parameter of interest that's present without epidural stimulation after it's been applied over time. So for example, using that same grip strength, if I applied epidural stimulation and grip strength improved over time, and then without the epidural stimulation, there was still an improvement in grip strength, that would be a therapeutic effect. Also, studies had to include original data. And then for the exclusion criteria, we excluded other types of stimulation. So for example, transcutaneous stimulation. We excluded reviews without original data and minor publications. We also excluded epidural stimulation when it was combined with an intervention other than movement or exercise. So a good example would be a pharmacological intervention. We also excluded animal studies or studies that investigated a neurophysiological mechanism, so EMG studies. Now moving on to our results. So this is a picture of that PRISMA flow diagram. So we started out with 7,770 articles. Then after deduplication, after screening abstracts and titles, full text, we ended up with 48 studies included in our scoping review. So the study participants were human. We had a total of 373 individuals with spinal cord injury or disease. There were 256 males and 47 female participants, and 70 of those individuals did not have sex reported. Their ages ranged from 8 years old to 67 years old. For the study design, there was almost an even split. So we had 23 non-randomized pre-post studies, 24 case study or case series, and 1 that was a case control. Again, going back to that critical appraisal, we used the Downs and Black modified checklist. So 30 studies scored fair in quality and 18 studies scored poor in quality. Just to give you a frame of reference, studies could score excellent or good as well, but because of the way these studies were created, it could only possibly score good, But even so, we had no studies that did score in that category. So now moving on to the descriptive analysis. So talking a bit about stimulation, location, and parameters, followed by complications. And also in the next bit of analysis, I'm going to return to a bit more about the stimulation, location, and parameters. So what we found was the optimal level of stimulation was below the spinal cord lesion. L2 was the best site to stimulate locomotion. Stimulation of the epidural space posterior to the spinal cord was optimal for most functional goals. And then with regard to parameters, we noticed that there was a range of epidural stimulation settings for different parameters, or it was just simply not reported. And these are the parameters here that we discussed. So frequency, pulse duration, and intensity. When we looked at complications, in 22 studies, there were technical and clinical complications. So technical complications included, for example, failure of lead conductors or insulation, and that happened in 11 individuals. There was electrode migration in 6, need for hardware replacement in 9, or additional components in 5. And then again, you have to consider these last 2 with the need for additional components or replacement. This is a technological piece of equipment, so it may not have necessarily been a complication, but just simply routine maintenance. We're not entirely sure there. And then in one case, there was a wire breakage that led to an ulcer, and there was also a wire that came through the skin. Now, if we wanted to talk about adverse clinical effects, they mostly consisted of mild leg jerks in 7 individuals in one study. There was infection in 6 individuals, urinary tract infection in 2, autonomic dysreflexia in 4, mild edema in 5, and mild flexion of the hands in 2. There were also 11 individuals that experienced one-off complications. The most major of those would have been 1 individual who had aseptic meningitis and 1 who had a spontaneous hip fracture. Now I'd just like to move on to the thematic summary. So returning to those functional goals. So just for a quick overview, before we get into them in depth, for improved bowel, bladder, or sexual function, there were mixed effects. This is indicated in yellow because there truly were mixed effects throughout the studies. For improved cardiorespiratory and cardiometabolic function, there were positive effects across studies. For pain, there were mixed effects. This is indicated in green because once we actually control for the site of stimulation, it was actually positive effects. And then in the following 4 categories, so improved upper extremity and lower extremity function, there were positive effects across studies. For decreased spasms, that's actually a correction. So there were positive effects in decreased spasms. And for decreased spasticity, there were actually mixed effects. So that should be in green. And once we controlled for the site of stimulation, it was actually positive effects. So now moving on to the bowel, bladder, and sexual function. So across 5 studies, there were positive results. So for example, bowel evacuation was faster and more complete. The time required decreased. And then there were some mixed results. So this included bowel and bladder synergy was mixed, and then sexual function was also mixed. You'll note that there were negative results within the range of 25 to 130 hertz, and mixed results within the range of 16 to 400. Typically, the positive results were in the range of 60 up to 120 hertz. So there actually might have been too low if they stimulated below 60 for smooth muscle contraction. And at high frequencies, there can be fatigue. So you might not have an effect as well. And then if you're looking at 2 different goals within studies, so for example, maybe voiding and then also bladder capacity, you actually need a low frequency for voiding and then a high frequency to increase bladder capacity. So there may have been some issues there. Now moving on to cardiometabolic function, there were positive effects in 5 studies. So for example, episodes of autonomic dysreflexia were eliminated in some complete injuries with epidural stimulation on, and then after 5 to 6 weeks, it resolved. And then in one study, these effects were not sustained over the long term, and the specific effects were thigh circumference and also lean muscle mass. But in the first 6 months, they actually engaged in multimodal rehabilitation along with epidural stimulation, and they were allowed to engage in that at home as well. And then, in the following 6 months, they also engaged in this as well, but we don't know what they did at home because that wasn't reported. So there could have been that effect as well. And then just from the other studies, we know that intensity, frequency, and pulse duration is individualized to normalize blood pressure without triggering skeletal muscle activity at the lower extremity. Now moving on to cardiorespiratory function. So there were positive effects across 8 studies. So this would be it prevented orthostatic hypotension when epidural stimulation was on, for example. There were increased maximum airway pressures and peak ventilation. And there was an exception of the abdominal portion of one study. But if we take a look to the literature again, the intensity plateaus after 30 to 40 volts or 15 milliamps. The frequency, it should be a high frequency for autonomic function and low frequency for motor function. So that might explain the issues with the abdominal study. And then just a note, above 50 hertz can cause complications. And then with regard to pain reduction, so there were positive results using a variety of settings. So this was reduction in frequency and intensity of pain. There were 2 studies with mixed results, but you'll recall I mentioned before, they actually stimulated incorrect areas. So they stimulated above the level of the lesion. And by stimulating above the level of the lesion, later studies didn't do that because they recognized that this wouldn't produce results. So the intensity, frequency, and pulse duration should be individualized to induce paresthesia, and then the frequency should be 50 to 150 hertz. Now moving on to lower extremity function. So in the scoping review, there were mostly positive results across 12 studies. So that include, I should mention that all of the studies used body weight supported treadmill training as well for step training. So some of these studies resulted in the amount of body weight support needed decreased. They also resulted in increased speed and endurance, for example. And then 2 wheelchair users actually achieved functional ambulation. And then talking about standing, there was increased standing time, and these individuals need less support to stand as well. And then talking about the negative results in one study, they actually used a frequency too low to stimulate locomotor type activity. And we'll talk about it, a bit about that in the next slide. So as you noticed, there were 13 studies that talked about lower extremity function. So this was the highest amount that made it into the review. So there's been quite a lot of research into locomotor and lower extremity function. So from the research, we can see that intensity at 4 volts, tonic starts. At 5 volts, there's rhythmic locomotion. At 5.5, well-organized rhythmic locomotion. Then for the frequency, 2 hertz will evoke a monosynaptic reflex. 16 hertz will generate consecutively generated reflexes. 22 to 50 hertz will stimulate locomotor-like activity. And then above 100 hertz, you have that tonic motor output. And then this is what happened in the previous study by Shapkova and Mushkin. They used a pulse duration of less than 500 microseconds. And again, this will result in no obvious effect on locomotion. And that's what happened in that study. Then if we look at upper extremity function, unfortunately, there was only one study, but it did yield positive results. And in this case, there was an increase in grip strength in the individual. And they used a range used to evoke minimal to peak motor response in this study. Then moving on to spasm reduction. So there were positive results in all 4 studies. And then, so this means that there was a reduction in number of spasms, so frequency and also duration of spasms. And there was positive results in one study, but it had a significant amount of complications. And it used a broader range with a higher frequency, so 2 to 1400 hertz. So again, there might have been that fatigue there. The intensity, if we look to the literature, should be between sensory and motor, but sometimes it's below sensory. And if it's too high, you can actually have a worsening of spasms. So that might be related to complications. If we look at the frequency, it should be between 2 and 120 hertz. But again, you don't want it to be too high. And then moving on to spasticity reduction. So if you recall, this one had mixed results in the initial chart, but again, if you control for the for where it was stimulated, it was actually positive results. So initially, there were 2 studies that showed positive results. So what happened there, for example, was that spasms were reduced so that one individual was able to walk. There were negative or mixed results in some studies, and these used a low frequency range. And also it stimulated, in one study, they also stimulated the anterior spinal cord and above the level of the lesion. So they weren't going to get a result there. The optimal frequency should be between 50 and 100 hertz. Okay, and now this brings us to our discussion. So I just wanted to discuss 4 major points. So the safety of epidural stimulation, the benefits, the location of the device, and then a bit about epidural stimulation and movement training. So first, talking about the safety of epidural stimulation. So over time, it's actually become a lot more safe. So we've developed multi-contact electrode arrays over time, and also with programmable devices. There's been minimally invasive surgery has developed. So this reduces surgical risks and time in surgery. And then also surgical techniques and device construction have improved. So this has led to a reduction in lead migration. And overall, this has led to improved clinical results and also fewer and less severe adverse events. So a bit of a wider use in research for epidural stimulation. Then moving on to the benefits of epidural stimulation. So I felt that in these studies, we found that an orthotic effect may lead to a therapeutic effect. So in one study, it actually had participants, it eliminated the need for airway suctioning. Epidural stimulation eventually decreased and eliminated spasms. Autonomic dysreflexia was eliminated, and also orthostatic hypotension over time, so therapeutic effects. But just one caveat, an orthotic use of epidural stimulation at this time did not lead to improved bladder function, sexual function, or standing ability as a therapeutic effect. Also, another benefit of epidural stimulation is that it could be used to train other functional goals. So I did mention in one individual, it suppressed spasticity. So this individual could walk further with less support. And then also in another individual, it suppressed spasticity. So they were able to engage in voluntary motor movements. And then also in another study, it improved cardiorespiratory function. And this allowed the individual to exercise. So it also has led to increase in lean muscle mass. This could lead to maintaining bone mass. This could also reduce other cardiovascular risk factors. And in general, this could have the epidural stimulation could have the potential to act as an adjunct or maybe substitute for other medications or surgery, depending on research. So now moving on to the location of the epidural stimulation device. So again, I mentioned that it should be below the level of the lesion. So above did have an effect, but it was in fewer participants or not at all compared to when it was stimulated below the level of the lesion. The positive results for L2 for locomotor function supports evidence for a central pattern generator located in the lumbar spinal cord. And then it should be stimulated at the posterior spinal cord in the epidural space, because stimulation at the anterior spinal cord produced no result when the posterior did. So this demonstrates the value of sensory input because the sensory neuron cell bodies are located in the dorsal root ganglia of the spinal cord. Now just discussing epidural stimulation and movement training. So movement training used with epidural stimulation in these studies, there was a high frequency. So individuals with spinal cord injury engaged in this training 3 or maybe 5 times a week, 80, maybe even 100 sessions, so quite high number. These sessions were long in duration, so an hour, hour and a half, 2 hours maybe. So you can see that this is quite a commitment, but it was actually not identified as a barrier by individuals living with SCI in the Anderson study. And in fact, they consider it part of a lifelong commitment. Now, there were some limitations with my study. So the terminology. So for example, older studies use the terminology incomplete and complete spinal cord injury only, whereas newer studies used the AISH scale, so AISH A through D. Then with regard to the participants, in one study, they included 2 individuals with multiple sclerosis with the study. So that could have affected results. And also some participants were in the acute stage. So perhaps it was due to the course of natural healing that they had some positive results. And then also the quality of the study. So as I mentioned before, some quality or studies were fair to poor in quality. Then future directions should include parameter testing further to get those more specific. And then also combine movement therapy with epidural stimulation. So now for my conclusion. So in conclusion, the effects of epidural stimulation on most functional goals, particularly locomotion, show promise. Researchers and funders can target this area, and with continued positive results, they can move towards steps to implementation and developing clinical guidelines. I just want to acknowledge my supervisor, Dr. Kristen Musselman, and co-supervisor, Dr. Cesar Marcus Chin, the other authors on this study, Dr. Cindy Gauthier, Dr. Kay Masani, and Maureen Prakash, and as always, the support from my SCI Mobility Lab members. Again, I'm sponsored by or funded by the Rehabilitation Sciences Institute at the University of Toronto, Kite University Health Network, and the Spinal Cord Injury Mobility Lab. Also, I just wanted to talk a little bit about a podcast. So it's called Spinal Moves, and it's Canadian conversations about activity-based therapy. There are 8 episodes, and I wanted to draw your attention specifically to episode number 6, where one of our guests is Dr. Andrei Krasyakov, and I interview him about epidural stimulation. And if any of you have any questions, I'd be happy to answer them at this time. And thank you for listening. You can find me at LinkedIn, Hope Jervis Rademeyer, at mail.utoronto.ca. And these are the citations for the manuscript and abstract. And these are my references.